Quick acknowledgments here. So I'm Dr. Four. I'm the director for the IHS Telebehavioral Center of Excellence, and we facilitate and host this training. And through our partnership with the University of New Mexico, the UNM Pain Center, Dr. Katzman comes from there, and a lot of our other attendees will be coming from there today. Our presenters. Dr. Bott, our addiction specialist, comes from the Department of Psychiatry. I also want to mention our IHS Echo. There's a couple of different echoes that run. One that's particularly important here or pertinent here is the pain and addiction echo. You'll see some information for that a little bit later on, and you will hear us mention that as well. I also want to point out the work that the IHS Prescription Drug Abuse Work Group has done. The website was stood up by this work group. This is where everything pertaining to pain management within IHS will be. It's been updated recently, but we're actually about to go through another really big update to include MAT and co-prescribing, two things that you'll be hearing about today if you're not already familiar with those terms. So hit that website. That is where everything official for IHS pain management is located. Here's the work group. Just very quickly, Captain Gunderson and Captain Rudd do an awesome job leading this group. If you are interested, we're always looking for more members. You can see these are the subgroup leads. There's really a lot of work still to be done, and we will be transitioning to a standing committee. So if you want to be part of that committee, contact myself, Captain Rudd, or Captain Gunderson, and we'll be happy to have you with us.
Thank you for everybody that's on the network from all over the country. We're here in Albuquerque, New Mexico, in the Southwest, and I'm going to be starting the course off today by talking to you today about kind of dual epidemics, the epidemic of unintentional opiate overdose deaths, and also the epidemic of kind of chronic pain in this country.
Sorry.
This is going to be a very short overview before we get into kind of the meat of the presentations, and shortly after my talk, you're going to be hearing Dr. Bott, our addiction psychiatrist, talking to you about screening for opiate addictions, misuse, and diversion. But I'm just going to kind of set the stage for the rest of the day. The objectives of my short talk are to recognize the epidemic of unintentional opioid overdose deaths in the United States, to identify the importance of education regarding prescription medication misuse and identification of patients at risk for addictions, and also to understand best practices in pain management to provide integrated and integrative collaborative care, and to really understand how pain management best practices really is important in order to curb the tide of unintentional opiate overdose deaths. The background is really that unintentional drug overdose deaths is a public health crisis. Opioids are frequently involved in the overdose deaths, and we know that they are not the only substance that's involved. Frequently alcohol is involved, frequently other respiratory depressants like benzodiazepines are involved, and frequently other illicit substances are involved, such as cocaine, such as methamphetamines. And there are increased rates in special populations, such as Hispanic populations have increased rates not only in opiate misuse, but in unintentional opiate overdose deaths, and in the American Indian population. Pain as well is a major public health issue, just like unintentional opiate overdose deaths. As a matter of fact, chronic pain, according to the Institute of Medicine, affects an estimated 100 million American adults. The Institute of Medicine report was published in 2011 based on a year to 2 long survey and research with many experts in the field of pain. It was also found that chronic pain costs up to $635 billion per year in treatment costs and lost productivity when patients suffering from chronic non-cancer pain cannot get back to work. And compared to people without chronic pain, people with chronic pain have roughly 3 times the rates of depression and anxiety disorders. We're going to be talking a lot today about the overlap of patients with chronic pain and addiction and opiate substance use disorders having mental health disorders co-occurring with them. And people with chronic pain have at least 2 times the risk of completing suicide. So you're going to see and hear today the overlap between chronic pain, opiate substance use disorders, unintentional death related to using too much opioids, but also the mental health overlap between these 2 conditions. So this is the Institute of Medicine report. What I'm going to let you know is that the leading sources of kind of chronic pain with these 100 million Americans are headaches, are chronic back pain, both upper back, middle back, and lower back, and musculoskeletal pain conditions in general, including osteoarthritis. Many surgeries take place, whether some surgeries are very much justified, and other surgeries perhaps the patient could have gotten away without needing a surgery and might need even non-pharmacological, non-surgical approaches, might have even been better. So just in terms of posing this issue a little bit a different way, chronic pain affects more Americans by far than the number of Americans suffering from diabetes, cancer, and all vascular diseases combined. So chronic pain is a huge issue, probably the #1 chronic disease issue we have in the country. And in terms of the financial burden, you can see just how big this is as well. In terms, now we're flipping back to the prescription opiate epidemic. From the 2013 National Survey on Drug Use and Health, 24 million Americans greater than or equal to 12 years of age had used a pain reliever non-medically at least once in their lifetime. Okay, huge amount of medical misuse in this country. The rates for medical misuse of opioids in this country, and these reports are from the National Survey on Drug Use and Health from 2015. The U.S. average is 4.2% of all Americans. For the Hispanic population, it rises to 4.9%, and for the American Indian population, it's significantly greater at 6.9%. Fortunately, with increasingly more available treatment options for medication-assisted treatment, we still have methadone, which we've had for many, many years. We now have buprenorphine, and Dr. Bott and many addiction psychiatrists are being able to give more courses in buprenorphine training, and we now have other products such as Vivitrol. And we now have harm reduction measures such as naloxone, which we'll be talking about later this afternoon. Medication-assisted treatment is shown to be extremely beneficial for patients with medication, for patients with opiate substance use disorder. So what are the sources of misused drugs? This is from 2010, and we have results from 2013 and 2015. But interestingly, the results haven't changed. We just have more data regarding this big piece of the pie. If I was to survey all of you, and there's more than 300 of you on the network right now, and say, you know, who do you think is really misusing opiates, not taking opiates for which it was prescribed from a doctor? Many of you might have said 5 years ago, oh, I think if people are misusing drugs, they're probably buying it on the internet. They're probably buying it from a drug dealer on the street. Well, that's not actually true. The vast majority, more than 50% of people, of Americans who are misusing drugs, are actually obtaining these medicines from a friend or a relative for free. The next biggest slice of the pie is that these Americans are getting it from one doctor, but then they're not taking it for their sore elbow, their knee pain, their abdominal pain. They're using it for a reason other than which it was prescribed. Let me just go back here real briefly. A much smaller pieces of the pie is that they're buying it from a friend or a relative, buying it on the internet, or stealing it. Let me ask you a question. Where do you think these friends or relatives are getting their medication? Well, the vast majority are getting it from one doctor. And this is where we all as clinicians, and many of us are prescribing clinicians, this is where we all can do a better job at screening our patients for opiate misuse. So this, I won't belabor this, this is just shows you what are the leading reasons, leading illicit drugs and alcohol in this country. Alcohol really still leads the list. So does cannabis. Heroin is being used more and more, followed by cocaine, hallucinogens, and inhalants. A recent survey, although it's not as recent as when I used it in 2010, 2011, but it still really intrigues audiences, and I think it probably holds true in your neighborhoods and your communities, is that teenagers now say it is easier to get prescription drugs than it is to get beer. And it's really, it's because it is very, very easy for teenagers and lay people to get opiates without going to a doctor or another clinician. This is from the Annals of Internal Medicine from December of 2015, just 1 year ago. I want to illustrate that for many patients who have had a near fatal overdose, they are still getting the same dose of their opioid from the same doctor even after they almost died. This says opiate prescribing after non-fatal overdose and associated with repeated overdose. This was a retrospective study looking at almost 3,000 patients between the ages of 18 and 64 who had chronic non-cancer pain in the 2 months prior to their index overdose. They were on a relatively high dose of an opiate. Interestingly, they did have a slightly elevated rapid escalation of their opiate dose 2 weeks prior to their near-fatal overdose. They were also, 56% were co-prescribed a benzodiazepine, which, as we know, is harmful. It does increase the risk of an unintentional opiate overdose death because it does increase the risk of a respiratory depression. 91% of these patients who had a near-fatal overdose were continued on the opiate medications even after the near-fatal overdose, and 71% were continued to receive the medication from the same doctor. So this was alarming to the authors, and now just one caveat: many of these doctors, these primary care doctors, did not know their patient had a near-fatal overdose. They were sent to the emergency room, they were hospitalized, they were let go, and there was some lack of communication. But nevertheless, these patients continue to receive their opiates. Just moving on now, there's many different definitions of chronic pain. Some are scientific, some are philosophical. The Institute for the Association of the Study of Pain says pain is a sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Margot McCaffrey, a philosopher, says pain is whatever the experiencing person says it is, existing whenever he says it does. Both of these definitions are correct, and this is what we teach to our learners. When the patient comes into our clinic, whether it's our pain center or our primary care clinic, we teach our colleague, our student, our medical, nursing, or pharmacy student that if the patient comes in with pain, it is our job to find out what the source of pain is. So for patients with chronic pain, these patients may not need opiates. Chronic pain may last longer than 3 months. Chronic pain may never go away. It's often neuropathic in nature. It's not useful as an alarm. It's often associated with depression, anger, and anxiety, and it's best treated with a comprehensive approach. In acute pain, opiates are extremely useful. As you know, if a patient has an outpatient surgery procedure or needs to come into the hospital for a night, comes into the emergency room because they broke their arm or leg or has an acute injury, they might need high doses of opiates for 1 or 2 or 3 days. Opiates are frequently the mainstays of treatment along with anti-inflammatories and sometimes adjunctive medicines. In chronic pain, opiates are sometimes useful, sometimes harmful. Some patients may need high doses, some may need opiates not at all. Many other medicines that Dr. Commercy will talk about early this afternoon are much better than opiates, such as serotonergic, noradrenergic, reuptake inhibitors, various neuropathic agents, topicals, transdermals. These can be used in various ways and can be in various ways helpful. We will teach you all about them. We will teach you how to use them. We even use opiate antagonists, such as naltrexone, for conditions such as fibromyalgia. And so we'll talk to you about how to use non-opiate medications in your chronic pain patients, and we will also teach you how to use opiates when justified and how to use them safely. But when you have a patient with moderate to severe pain, you might want to think about an interdisciplinary team, and if you don't have one, you might want to think about presenting your patient to our Indian Health Service UNM combined echo. We've just recently combined to have a weekly IHS UNM echo clinic, and you can present your patient to us. As you know, there's no single primary residency that treats chronic pain. We all treat chronic pain, whether we're a dentist, a pharmacist, a primary care provider, a physical therapist, an interventional doctor, a surgeon. So we all need to know how to treat chronic pain. We're all really on the front line. There's many educational challenges. All residencies now require various levels of chronic pain education. The biggest take-home message here is that it's very, very important to document function in your chart. Not just does their pain level go down, perhaps from an 8 to a 3 or an 8 to a 4, but is their function improved? Did the patient go from lying on their couch all day to go to be able to walk around the block or play ball with their grandson? It's very important for you, if your patient is on an opiate analgesic, for you to document the improvement in function, okay? We also try to teach the fact that patients do have pain. We need to try to get to the source of their pain, whether it's organic pain, whether it's emotional pain or psychic pain, but we also want to teach a comfort for using opioids when indicated. It's our real ethical obligation to prevent, to diagnose, and to treat uncontrolled pain. We want to prevent, to diagnose, and to treat substance use disorders. We want to minimize risk and maximize benefit, and we want to deliver patient-centered care. The National Pain Strategy came out in 2015. This kind of followed the Institute of Medicine report, and it really talks about the fact that we really need to improve our medical management of pain to combat stigma. We really need to improve patient self-management, and we want to really demonstrate that primary care clinicians really are on the front line. I'm going to leave this here with you. These are the CDC guidelines for prescribing opioids. These are just guidelines. They're called guidelines. They are not rules. They're primarily excellent. They talk about first thinking about non-pharmacological approaches for your patients with chronic pain, exercise, weight loss, mindfulness, behavioral therapy, psychotherapy, and then if this is not proving too fruitful for your patient, then considering non-opioid pharmacotherapy. And then if this, again, is not too helpful, you might then want to consider starting your patient on opioids only if the patient has a condition or a diagnosis that does justify opioid analgesics. But before you consider opioid analgesics, you want to establish goals for pain and function and make sure that this patient has been screened adequately for addiction, aberrant behavior, and knows the risks and benefits of opioid analgesic therapy. Also, if you're going to put your patient on opiate analgesics, you might want to consider co-prescribing with naloxone. And you have these CDC guidelines in your PowerPoint. Many of you have been sent them to you from the U.S. Surgeon General Murthy. And I think I'll leave the talk here, Dr. Four, and allow Dr. Bott to get started.
Sounds good.
Yeah.
Hi everyone, Snehal Bhatt here from the University of New Mexico Department of Psychiatry and Behavioral Sciences, and also have been privileged to work with the Indian Health Services for the past several years now. Okay, so I'm going to talk to you about screening for addiction and monitoring for aberrant behaviors in our patients with chronic pain. Few objectives. We're going to define and distinguish the concepts of addiction, substance abuse dependence, and pseudo-addiction. Identify some of the epidemiological and clinical risk factors for aberrant behaviors in populations with chronic pain. We'll really demonstrate some clinical tools to assess the risk of addictions in our patients in whom we may be considering starting prescription opioids. And then finally develop practical strategies to manage aberrant behaviors when and if they do arise. So, I'm going to start with a tall order, a controversial statement. And as I read it, just take stock of yourselves to see if you agree with this or disagree with this or where you are. And as we go through the presentation and as the day, see if that shifts a little bit. I strongly believe that physicians can be trained to prescribe opioids for chronic pain safely and effectively, right? So that's hopefully what we're going to work towards over the course of the day. When we talk about responsible opioid prescribing and opioid risk management, there are really three components to it. First is being familiar with individual risk factors for opioid abuse, something a patient already brings with herself or himself when she comes to see you. Second is using risk assessment tools. And the third is monitoring for aberrant behaviors during ongoing treatment. And if we do all three of these, I think it can lead to responsible prescribing. And in the next 35 minutes or so, we're going to try to cover all three of these factors while keeping in mind the tall order that Dr. Katzman laid out, right? Our ethical obligations of beneficence, non-maleficence, justice, and autonomy. And as Dr. Four pointed out, keeping in mind sort of a patient-centered approach. So what is addiction? So over the past several decades, a lot of research has been done. And ASAM, American Society of Addiction Medicine, defines addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. We know, and some of these models are fairly well established, that when a person becomes addicted to a substance, he or she's brain mechanisms are essentially hijacked by that substance of addiction to a point where the person comes to see that substance as being necessary for survival. Think about that for a moment. If we think something is necessary for survival, that's going to take precedence, maybe at sacrifice of all the other things that may be important. Dysfunction in these circuits leads to characteristic biological, psychological, social, and spiritual manifestations. Many of you are in the front lines of treating patients with chronic pain. See this, how addiction starts to affect all areas of a person's life, not just the physical, but also some of these other very important aspects. This is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. Right? So here I want to pause a moment and distinguish between addiction and pseudo-addiction. When you talk about addiction to a substance, us addiction psychiatrists often talk about the C's of addiction. It's a quick and dirty way of saying whether someone is truly addicted to a substance. The first is cravings. Well, that's one of the C's. When a person is addicted to a substance, they'll often have cravings to use this substance. Maybe when they're stressed, maybe when they see that substance, the cravings become very strong. Second is consequences. When a person becomes addicted, it starts to lead to consequences. The patient may tell you, Doc, it's getting me into trouble with my spouse. We're having conflicts, or maybe I'm having legal problems now, or I lost my job, I'm spending all my money. The next C is control, or the lack thereof. When a person is addicted, the use starts to become out of control. The person may use more than they intended, for longer periods than they intended, right? Or in larger amounts than they intended, and maybe spend a lot of time either being intoxicated or recovering from the effects, or spending time trying to obtain the substance. Another C is compulsivity. The use becomes compulsive, right? It's no longer an impulsive thing, but the patient has to compulsively use. A patient may tell you, in the first thing in the morning, I have to reach for that beer and put it in my mouth. And then, finally, unsuccessful attempts to cut down the use. The cut down is the last C. The patient may say, I've tried to cut down, I've tried to stop, unfortunately it just didn't work. And addictions tend to follow a chronic relapsing remitting course for many of our patients, right? Contrast that to physiologic dependence, which is where that's something that happens to many medications, right? For example, a patient of yours who may be on topical steroids will become physiologically dependent on medication. That medication may even happen with some type of, so for example, stimulant laxatives. And if a patient stops suddenly, they will go into characteristic withdrawals. However, in physiological dependence alone, you don't see those other wider and maybe more deleterious manifestations of addiction. Pseudo-addiction is another term we use. Pseudo-addiction is when a patient comes to you and says, well, I need a higher dose, or maybe I would use the higher dose of the opioid. But when you really obtain the history, they use the higher dose, maybe because their pain was inadequately controlled, right? And again, those other C's, the other wider manifestations, are not present. One quick way to distinguish between pseudo-addiction and addiction is functioning. In addiction, if you go up higher on the dose of the medication, as the dose escalates, the functioning certainly will not improve and may actually worsen. Versus in pseudo-addiction, often going up slightly higher on the dose, if it controls the pain adequately, the functioning may improve. So I just kind of wanted to point that out. Another term I wanted to point out is aberrant behaviors. So what is an aberrant behavior? Well, it's a behavior that suggests prescription misuse, abuse, or addiction. So it's often an early harbinger to addiction before it actually manifests, so very important for us to recognize. I'm going to read this quote verbatim because the next 3 or 4 slides are going to try to break it down and explain it in further detail. I think this is a very important quote. Prescribing opioids will lead to abuse or addiction in a small percentage of chronic pain patients, but a larger percentage will demonstrate aberrant drug-related behaviors and illicit drug use. These percentages appear to be much less if chronic pain patients are pre-selected for the absence of a current or past history of alcohol or illicit drug use or abuse or addiction. So now let's try to break it down, right? This quotation. So what is the prevalence of addiction in chronic pain patients? I often ask this to my trainees or even people I'm giving the talk to, and people often tend to come up with a number around 30 or 40%, roughly. In fact, what the data show us is that number is much, much lower. Some of the early studies that were done in the 80s showed that the prevalence was almost non-existent, but those studies weren't well done. Some of the later, smaller studies showed prescription of addiction at like 60, 70%, but again, those studies also suffered from methodological problems. This was a big study that came out, done by Fishbane in 2008, looking at over 2,000 patients. And what Fishbane found was a rate of addiction for about 3.25%. So much, much lower than what we would think, right? Or what we would intuitively think. And if you pre-selected patients with a history of prior substance use disorders, so if you only looked at those patients who were on prescription opioids who had no prior history of substance use disorders, that rate actually dropped to 0.19%. Some of the newer studies, most notably the one done by Dr. Kevin Voles here at UNM that came out in the journal Pain last year, have put this risk higher, right, as many of us might have guessed. And the Voles study really showed that about roughly 10% of patients, chronic pain patients who were prescribed opioids, developed abuse or addiction. And those numbers, believe it or not, somewhere between 5 and 10%, tend to be ballpark for a number of other large studies that have been done over the last 5 or 6 years. So again, the take-home point here being that the number of people who actually develop addiction is probably a lot lower than what we might imagine. However, aberrant behaviors are much more common. This is a study that looked at, again, over 2,000 chronic pain patients and found about a 20% risk of patients going on to display some aberrant behaviors, so much higher than the people who actually eventually went on to develop abuse or addiction. And I think that's why it becomes very important for us to be able to recognize and manage aberrant behaviors when they do arise. Interestingly, the Voles study that I just cited had aberrant behaviors also pegged at just about 20%. Right? So moving forward, what are some risk factors for aberrant behaviors? So this is the first part of responsible prescribing, looking at individual risk factors. So let's go over them. One, and the biggest by far, is lifetime history of a substance use disorder, including, don't forget, alcohol, tobacco, and I would add to that cannabis, right, in our current climate. So those are included. So lifetime history of substance use disorder is by far the biggest predictor for development of aberrant behaviors. Psychiatric comorbidity. Some of the big psychiatric comorbidities include antisocial personality disorder, panic disorder, post-traumatic stress disorder, and bipolar disorder. Those tend to be more closely associated than maybe other illnesses when it comes to development of aberrant behaviors. History of pre-adolescent sexual abuse, trauma, right? And unfortunately, all of us in the front line see this trauma and the devastating impact it can have on our patients, even years or decades down the line if unaddressed. And this is no exception. Family history of substance use, history of legal problems, younger age, and increased functional impairment are all personal risk factors for developing aberrant behaviors. This was a study done by Boscarino a few years ago, I guess about 5 years ago at this point. So Boscarino, in this study, what they found is if you took a patient whose age was over 65, who had impairment due to pain, had major depressive disorder, and used psychotropic medication, that patient was about 8 times more likely to develop dependence on prescribed opioids. However, and this is the striking part for me, if you added to that constellation a history of prior opioid abuse or dependence, that odds ratio jumped to 56. So all of a sudden that patient became significantly more likely to develop a dependence on the opioids you might prescribe. So again, the take-home point being that if you have a patient with a prior history of opioid use or dependence or a substance use disorder history, be mindful of that as you formulate a treatment plan, right? Now, not all aberrant behaviors are created alike. So here what we've done is try to break it down into sort of green light, orange light, and red light to help you distinguish between these behaviors and recognize them when they arise. So these are kind of the milder aberrant behaviors. Number one, requesting higher doses. Maybe part of it is that pseudo addiction we talked about, right? Maybe the dose prescribed just isn't adequate and patient is requesting a higher dose because they're in a lot of pain. Or maybe they had a busy weekend. As Dr. Katzman said, maybe they played ball with their grandson or did something else and now they're in more pain and that's why they're requesting a higher dose. Key thing here being functioning. If this is the case, as you raise the dose, their functioning should improve, not worsen. Just keep that in mind, please. Requesting specific formulation. Even when I trained, this was sort of a big red flag, right? The patient must be wanting to abuse that medication if they're asking for that specific formulation. However, days have changed, right, very rapidly. We all see commercials that say, talk to your doctor about such and such medication. Patients are getting that message, right? They're getting bombarded with advertisements. Maybe they heard about it. Maybe they know someone who's used the medication. And that's why they're asking. Talk to the patient. Going back to Dr. For's point about being patient-centered. Talk to the patient and maybe you can resolve this. Occasional loss of prescription. Occasional increase of dose without permission. Again, the key word being occasional. And never let even these mild aberrant behaviors go unaddressed. Talk to the patient and address it, right? I think that's one of the biggest take-home messages, and I teach this to everyone I work with, that if you have a concern, be open with the patient, be transparent, and bring that concern up and address it. Now we get into some of the moderate or orange light aberrant behaviors. Use of prescription to treat symptoms other than pain. The pain medication prescribed should be for a specific reason, a specific type of pain, or maybe a specific location of pain. Sometimes we all have encountered patients who start using it. Well, doc, I was feeling very anxious. I had a rough day, so I took an extra oxycodone to feel relaxed. That should raise an eyebrow, and that should be addressed in session. Stockpiling prescriptions, right, for a rainy day. Significant energy spent assuring supply. I've got that other doctor who can give it to me. I've got an aunt who has some extras if I really need it, and a friend. Now we're getting into that compulsivity that may be suggestive of impending addiction. So we should be very mindful of it. Multiple unsanctioned dose escalations, recurrent prescription losses, decline in function from baseline, and concurrent use of other illicit substances should all make us concerned. Finally, we go into sort of the red light zones, the severe aberrant behaviors, continual escalation of dose, seeking prescriptions from other providers or ER, stealing drugs, consistently buying prescriptions off the street. I think these pose a significant danger, not just to the patient, but also to the community. And for many of us who practice in tight-knit, traditional communities or maybe small rural communities, maybe the community impact tends to be even greater, right? Because other members may be affected very severely. So I think we have to be mindful of that. Finally, the really severe aberrant behaviors where you may really want to consider whether opioids should be used at all in this patient, I think would be diverting or selling prescriptions, forging prescriptions, injecting oral prescriptions, which can be very dangerous and potentially fatal. So just a little guideline of what some aberrant behaviors are. So that's the first part. The second part of responsible prescribing, if you remember, was risk assessment tools. As I point this out, just a couple of caveats. First of all, like many tools, many standardized measures, almost none of them are tested specifically on our native populations, right? Even if we sort of lump together and say a native population, which would be naive, I think, it's just not been tested in native populations. So that's a big caveat. And the second caveat is that some of the recent data has suggested that by themselves, these risk assessment tools are actually not as predictive as we once thought. And that's actually pointed out in the CDC guidelines that came out in 2016. However, and CDC sort of agrees with this, that this is one of the many tools that we use, right? This is part of, we're doing as much as we can to make this a safer practice. And this is one of the, so you shouldn't use this by itself, but combine it with other practices that we're talking about. So just a couple of those caveats. There are many risk assessment tools out there. The one that we tend to recommend, and not because we have any financial arrangement, not because we get any kickbacks, but because it's been well validated in chronic pain patients in primary care samples, is the SOAP-R. SOAP-R is a 24-item patient-reported, questionnaire. It talks about many risk factors like mood symptoms, family history, legal history, functioning, right? And it actually comes with associated monitoring and treatment recommendations. And it tends to be fairly sensitive and specific. So if someone scores low on it, the negative predictive value, as you can see, is very high, which means that if someone scores very low on the SOAP-R, you can be reasonably, comfortable that the patient is at a low risk of developing aberrant behaviors or addictions to a person to the prescribed opioids. On the other hand, if you look at it, the positive predictive value is lower. So in other words, not everyone who scores high is going to go on to develop dependence. And that's where our interventions come in. That's made available to you. What we recommend is maybe even before the first visit, if you're considering starting opioids, have the patient fill this out when they're waiting in the lobby. And when the patient comes into the clinic, talk to them, go over the questionnaire with them, and sort of discuss the implications of it in terms of their treatment with the patient. Now, another tool that we recommend is the CALM. CALM is the Continuing Opioid Misuse Measure. So if SOAP-R is something you do at the beginning of treatment, CALM is something you do ongoing, periodically, about every 6 months, once you've begun to prescribe opioids to that patient. What it's done to do is it looks at self-reported medication use behaviors over the previous 30 days. So it's designed to pick up patients who may be using the medications in an aberrant pattern. So this is something I would recommend doing periodically when you do a treatment plan update, and documenting that, again, just scanning it in or documenting it directly into your EHRs for those clinics that do have EHRs. Right, so that's just a little bit about them. How do you use the risk assessment tools? So once again, don't use them in isolation. Right? They should also not be used to deprive patients of pain management. They shouldn't be like a way to sort of say, can't do that, opioids are just not an option. They may not be, but by themselves, the opioid risk assessment tools shouldn't lead to that conclusion. They should only be used with informed consent, with advisement that if you refuse to allow us to do these risk assessment tools, we may just not have enough information to prescribe you opioids, and it may alter our treatment plan. They should really be used to help guide us to determine the frequency and intensity of monitoring, right? So intensity and frequency of monitoring should fit how at risk the patient is for aberrant behaviors or abuse or addictions, and this is something that's designed to help us formulate that. and they should be used ultimately to develop the most efficacious and safest treatment strategies. Moving along, so just some recommendations, and these are of course available to you. So say I see Dr. 4 or Dr. Chowdhury for pain management, and they give me the SOPAR, and I come with a really high score of over 21. Again, I would recommend discussing it with me, right? So Dr. 4 might tell me that we know from experience that someone who scores this high on the SOPAR, like you, may be at a higher risk for developing problems or even addiction from using these medications. We want to be able to treat you. We want to be able to help you. So these are some things we can do to ensure that we can prescribe this medication safely and actually help you. Very different message than Dr. 4 just, I guess arbitrarily to me saying, we gotta only give you 1 week of this medication, we're gonna check a urine every week, and then I might come up and say, well, my neighbor is seeing you and my neighbor is getting 3 weeks of the prescription and not getting her urine checked every week. So what's going on, right? So again, going back to open, transparent discussion with your patients. I'll keep stressing it until you guys are ready to, kill me just from or get bored of it, but I'll keep saying it. So someone who scores this high on the SOPAR, you want to review past medical records, contact prior providers to get collateral information. These are the patients where you may want to dispense very small quantities of the opioids if you do start opioids at all, right? Maybe just 1 week at a time with a stated expectation that we will be checking a urine drug screen at every visit. Check in, have frequent check-ins, maybe consult with addiction specialists or other psychiatrists or maybe with pain management experts for these patients. And if patients continue to display aberrant behaviors, you may want to consider tapering them humanely if possible off of the opioids. On the other hand, if they do well, if their functioning is improving, if they're complying with all the expectations, then you may want to slowly give them more at a time, right? And reduce the intensity and frequency of treatment and monitoring. And then it goes on from there. Patients who score very low on the SOPAR, as I said, are actually statistically at a very low risk for developing dependence or abuse. So you can sort of be reasonably comfortable with it. And someone who scores between 10 and 21, it's somewhere in the middle. You start with fairly significant intensity of monitoring. If they do well, gradually sort of give them more leeway, and if they continue to struggle with it, slowly increase the intensity and frequency of treatment. Right? So again, you always want to match what you're doing to how the patient is doing. Balancing benefits and risks. There are no absolute rules. You're always weighing the risks and the benefits, and you want to involve the patient as much as possible in this decision making. Make it a shared decision making, and document your reasoning, for continued use. So document what your logic is behind the treatment plan that you have created for a particular patient, and obtain early and frequent consultation for challenging patients and problem behaviors. So before you become overwhelmed, maybe seek help from a colleague. It just makes it easier to have that team approach with some of these very challenging patients. Judge the treatment, not the patient. I know sounds like an obvious thing to say, but sometimes with our very challenging patients, we can all, myself included, fall into this trap. It's not up to us to judge if the patient is good or bad, or if the patient deserves pain medications. What we as providers have to determine is, do the benefits of this treatment outweigh any side effects and risks of harm to the patient or to the society, to the community? And the CDC guidelines that came out really do emphasize this point as well. Some of the benefits might include the patient's functioning improving, the patient's pain being reduced, right? Maybe job, work, etc. On the other hand, some of the harms might include things like risk of addiction, cost to society, and side effects of the medications. And these are the things hopefully you're discussing with your patient at your visits. And keep in mind, as I pointed out, that by themselves, risk assessment tools are far from the gold standard. On the contrary, the clinical interview and judgment remain the gold standard of risk assessment and management. Talk to your patient. Learn from your patient. And keep in mind that patients with addiction may be less likely to use illicit drugs if painful conditions are controlled. So someone who has a history of addiction doesn't mean that you automatically should exclude opioids if they're indicated. All it means is that you're providing the necessary intensity and frequency of monitoring to ensure that you're able to do it in a safe way and help the patient improve her function. Let's see, kind of moving forward in the interest of time, we've got about 11 minutes left. Now, risk management. We recommend that you approach all patients with universal precautions, that every patient is potentially at risk of developing abuse or addictions, but patients may be at differing amounts of risk, and that's what we've been talking about. Some of the tools that you can use to manage this universal risk is things like opioid agreements, and we're actually going to go into a lot more detail during the course of the day, so I'm not going to go into that too much right now. Risk screening and ongoing assessment, as we've talked about. Monitoring urine toxicology, very important. Just like you wouldn't treat a patient with diabetes without monitoring their hemoglobin A1C levels, you wouldn't treat someone with opioids without monitoring urine toxicology. Prescription monitoring programs, which are now mandatory and available in 49 of the 50 US states, and we strongly recommend it. Pill counts for those at high risk. At my clinic, being an addictions clinic, everyone's at high risk, right? So all of our patients have this stated expectation when we begin treatment, so everyone knows about it, that once every 3 months they'll get a call from our clinic saying, hey, can you come in for a random pill count? And we give them 48 hours because they may be living, some of our patients are living 3 hours, 4 hours away. So we don't want to make them come within the next 4 hours, right? That wouldn't necessarily be humane. We give them 48 hours to come in. When they come in, one of our nurses or MAs checks their pills to make sure the right amount of pills are there. They give an observed urine actually, and they can go. And the whole process takes about 15 minutes, but it's an important tool in this risk management. Frequent visits with limited number of pills dispensed for those who may be at high risk.
This is Dr. Four. So I mentioned the IHS Pain Management website. There is now a policy on PDMP that's there. If you're not aware of that, please go and review that. That as IHS prescribers, there's now a policy on PDMP that the expectation is that you will be checking and entering data into that. The other thing to know for our tribal partners who may be on today, that you may or may not have access to the PDMP. We've heard from some tribal programs where they actually have to negotiate an individual agreement with the state. So just be aware of that can be an issue for you. But for IHS, there's a clear policy out there now that was developed by the pain work group I mentioned earlier, so please check that out.
Thank you, Dr. Ford. Again, opioid agreements we're going to go into in a lot more detail as the presentation goes on. Urine toxicology, always do it with informed consent, with the idea that if you don't provide us consent to check urine toxicology, we may need to alter a treatment plan to make sure that what we're doing is safe for you. Use the results therapeutically and know the limitations of toxicology results, right? For example, something like oxycodone, so many of our synthetic opioids will not be shown in sort of an opioid result in point of care testing. They have their own categories. Similarly, buprenorphine or methadone have their own categories and they won't be picked up by a standard opioid test. Also, there are positives or negatives. And there may be slight differences from lab to lab and from location to location when it comes to this. So get to know the person who's in charge of your labs. I found that they're super helpful. I actually just met with our lab director last week and I had about 15 or 20 questions for him and he was super helpful in guiding me through it. I have him on my speed dial practically. So, get to know her or him. And they can help you with some of the more challenging urine toxicology results. Let's see, and adjust the frequency of monitoring to the level of risk. Manage these aberrant behaviors when and if they do arise within the practitioner-patient relationship. Medicalize it. Don't stigmatize it. Talk to your patient. Similarly, ask and try to empathically understand the reasons for the behavior. What happened? And be open and non-judgmental regarding the explanations the patient provides, even if you're skeptical about it. Some of the questions for patient and practitioners may be for the patient, were you confused about how to take the prescriptions? Did you think more pills equals more relief? Right? Often a common thing in our culture. Were you overly active and then have more pain and take more pills? Have you been depressed or anxious and the drugs made you feel better? The questions to ask ourselves: has the pain condition changed? Has it progressed? Is there a new pain generator? Is there an undiagnosed psychiatric condition, in which case maybe the appropriate thing to do is to refer the patient to behavioral health? Have you set and followed limits and rules that we've been talking about? Very important. So what do you do if mild to moderate aberrant behaviors, those green or orange moderate aberrant behaviors do arise? So these are some suggestions. Increase the frequency of visits, even if they're brief check-ins with the nursing staff. With permission, obtain collateral information, obtain family support for the patient, for the plan, increase the frequency or sophistication of toxicology screening, and maybe start to provide smaller frequencies and quantities of opioids and other controlled substances. In other words, bump up the sophistication of your treatment, bump up the intensity and frequency of your monitoring. Sorry? Okay. So when do you taper opioids? So you taper opioids, we recommend, when they're moderate to severe aberrant behaviors that continue despite repeated warnings and implementation of more close monitoring. So you tried this thing. The patient began to display some of these moderate behaviors. So now you're checking their urine drug screen more frequently. You're providing smaller quantities. You involve the spouse or the significant other in the treatment plan, and yet some of these behaviors are continuing. Or maybe the functioning is continuing to worsen. This may be a good time to consider tapering opioids if the potential benefits of the treatment are outweighed rather by the potential risks, right? We recommend a humane long taper if it can be safely done, because unfortunately we see this. Someone is abruptly stopped off of the prescribed opioids, and guess what can sometimes happen? The patient may turn to the street for illicit opioids or something like heroin, which of course comes with myriad risks. So try to do a humane long taper if it can be done. Begin alternative pharmacological and non-pharmacological and even traditional modalities of treatments for pain as you begin this taper, and don't abandon the patient even if you do refer. And I think it's important to point out that just because you're tapering opioids does not mean that you're abandoning the patient. You can still do a lot of these other things and help the patient, treat the patient, just not with opioids. When might you stop the opioids? Well, you may consider just stopping the opioids fairly quickly or even at that point if they display aberrant behaviors that we had sort of done in red text, the really dangerous behaviors such as injecting oral medications, selling prescriptions, or forging or stealing prescription. Because maybe these are the aberrant behaviors that represent a danger to the patient and to the public. And these may be the times when you may want to stop the opioids. When do you refer them to an addiction expert such as myself? Well, some of these behaviors you may have seen in your practices, right? Patient is doing aggressive demands for medications. They're forging or stealing prescriptions. Maybe they're selling or diverting medications, obtaining drugs from multiple prescribers, injecting oral or topical medications. They've developed an addiction to the substance. It's no longer safe to prescribe medications. Certainly someone like me can be of help. One of the great strategies for a patient like this who has become dependent on opioids, addicted to opioids, may be opioid replacement treatment, right? Medication-assisted treatment, often with buprenorphine, which we've begun to really train IHS providers and other providers in to give you that tool to be able to manage that addiction. And remember that you can do an online consultation through our Echo Clinic. When do you refer them to a pain expert such as Dr. Camarada or Dr. Katzman? If you're uncertain or if you have questions about whether to use opioids or treat chronic pain. Patient is very complex. They have multiple comorbidities and they need opioids chronically. Maybe the complexity and risk profile is so great that it requires a level of documentation and monitoring that's just not available in your practice setting. Or if the intensity of pain and disability requires other pain interventions, which you may not have the capacity to provide, a pain expert can certainly be an appropriate person to refer to. So as we come to a close here, in summary, the management of chronic pain with opioids, it's challenging certainly, as all of you know, but it can also be extremely rewarding. When you see a patient's functioning improve, when you see a patient doing well, it can be very rewarding in my experience. And I think in the experience of many people who are sitting around the table and maybe joined us for this seminar. It's our responsibility as the practitioner to provide evidence-based risk assessment, individualized treatment plan, and ongoing monitoring, not just of adherence, but of impairment and also functioning and psychiatric and addictive symptoms. And if we do all of these things, I do think that it can lead to responsible opioid prescribing. Thank you so much, and we'll move right along.
Great. Thank you, Dr.